see my screen? Just
Yes,
someone
Prof.
please confirm.
Yes,
Yeah.
we can see the
So,
screen.
I mean, I thought, many of us, deal with acute, pelvis fractures, and certainly that's what you expect when you hear of pelvis fractures, that someone fell off a height, or they came off their motorbike, or they were T-boned when they're delivering your Uber Eats pizza. So that's certainly, in our setting, the commonest type of pelvis fractures that we see. But actually, in the global north, the countries with mostly first world countries, but also with a much higher life expectancy, you know, pelvis fractures affect mostly elderly patients more than young patients. In the same way that you'd be surprised that in England, for example, they see more open fractures more open ankle fractures in elderly patients compared to young patients. So it's a similar thing with the pelvis fractures. There's more and more occurring in elderly patients, and most of those then go on to become pelvis fragility fractures. So they are called fragility fractures of the pelvis. And if I say FFP, it doesn't mean fresh frozen plasma, it's fragility fractures of the pelvis. So I can't keep saying that whole mouthful the whole time. So I'm going to say FFP. So, I mean, for tonight, the whole idea is not that I'm going to give you a very scientific talk or extensive literature review. We're just going to go through some case examples, and that's going to help me communicate, our current practice and what informs our philosophy. It's like I say, when it comes to geriatric fractures and fragility fractures, I'm gonna try and give you like a quick touch in 1 hour, but actually it's a massive part of orthopedic trauma. You can go onto a 2-day course of on fragility fractures only and orthogeriatrics arranged by the AO. And if the course wasn't enough for you, then there are also textbooks written on not only orthogeriatrics, but also pelvis fragility fractures. So if you're interest, please go and get yourself access to one of those books. And importantly, this is something that you have immediate access to, which is the AO Orthogeriatrics app. So please download it. It has a nice information on just treatment of patients with osteoporosis and low energy fractures. So the whole idea about tonight is that I want you to unlearn some things and relearn, new information. And the first thing that you must unlearn is that when you see this kind of a fracture in an elderly patient, it is not a stable fracture. It's only stable in young patients. And of course, the sort of outcome that you expect from management of this is that, you put them in the ward and tell the physio to mobilize them. And when they can straight leg raise, then they can go home and probably never see them again. And all the young patients with this, like the so-called old lateral compression 1 fracture, will go on and unite. But it is not always the case in elderly patients. So you must learn now that these particular cases present a challenge for geriatric fractures. So what you see on the left of your screen, again, it looks like, just a run-of-the-mill, lateral compression type pelvis fracture. And if you follow it up and it doesn't unite, it progresses. And what you have on the right is the same patient 6 weeks later. So if you discharge them and never see them in 6 weeks, that's what happens. And don't get me wrong, I'm not saying it happens to all the geriatric patients, but it happens to some of them. So you need to follow them up. And so don't just discharge them at on day 3, day 4, when they can mobilize. So call them back at 6 weeks and re-x-ray them, because some of them will displace. And the reason that they displace and they don't unite is that many of them have osteoporosis. And by way of definition, what is osteoporosis? It's just a disease characterized by low bone mass and structural deterioration of bone tissue. Importantly, in these fractures, these are not pathological fractures. So osteoporosis doesn't give pathological fractures. So a pathological fracture implies that there has been a disease process that's infiltrated the bone, and often that's a tumor. But in osteoporosis, it's just loss of bone mass, but there's no bone infiltration. So why do they matter? Like I said, we're seeing an increase. There's been a 23% increase over the last 3 decades every year. And, after the age of 60, when osteoporosis tends to kick in, 94% of pelvis fractures seen are fragility fractures in nature. They're not high energy fractures. And again, by definition, a fragility fracture is a fracture that you sustain from a standing height. So if you stand and you fall and you break a bone, whether it's radius or ankle or proximal humerus, that is just by mechanism of definition, it's a fragility fracture. It is which differs, for example, from something like a stress fracture. So a stress fracture is normal bone, and you just have repetitive micro trauma, so that gives you a stress fracture. Um, so in all these patients, like I said, osteoporosis is a risk factor, and unfortunately, there's associated mortality with osteoporosis, because often it goes undetected by surgeons, and that is where our role comes into play. And like I said, now if you look in the more developed world, 3/4 of pelvis fractures in any unit will be patients who are elderly in terms of age. So again, just to undo this linking, this association in your mind that pelvis fractures only affect young patients, and they are high energy injuries. So going back to FFP, so again, why they matter is that they are not, many people are not familiar with the concept. As a result, they often get mismanaged. And then when we classify pelvis fractures, we tend to use the Young and Burgess or the AOOTA classification. But this classification is meant for high energy injuries in in young patients, and it doesn't cater for FFPs. And these fractures differ from young patients in that, like I said, if you have a young patient, you expect stability to increase over time and they unite. Whereas in the elderly patients, there is propensity for this instability to increase over time. So it's quite the opposite. So please take a screenshot of this or take a picture with your phone. This is the article that first described the classification of the FFPs. So just be familiar with it by Romans and Hoffman. So how they go with the classification, basically you look at the anterior lesion and you look at the posterior lesion, and very similar to young patients with elderly fractures, anterior lesions are a little bit more forgiving and posterior lesions are far more serious. So classification goes from A to K, or 1 to 10, K, 11. So just and it progresses from front to the back. So you have one part of the ring involved anteriorly, or you can have bilateral anterior involvement, or you can have unilateral posterior and then ipsilateral posterior involvement with anterior involvement, and like that it progresses up until what you've got with the last one, which is bilateral posterior involvement with involvement of the anterior part of the ring. So be familiar with it, please. So, if you speak to anyone, and I can talk to any of you, when you see this patient, there is no question that this kind of, fracture requires an operation in a patient that is fit for surgery. You will not even think twice, and the only discussion you're going to have is whether you're going to do total versus hemi, cemented versus uncemented, hybrid is going to be metal and poly, ceramic and poly. That's the discussion, but it's never whether they need surgery or not. And again, many of the institutions, when you see a distal radius fracture, it's often quite treated aggressively, either most of the time with surgery. Some places will give you a pop and some will give you K wires and pop, but it's always treated, aggressively. Same thing with vertebral compression fractures. They do kyphoplasties and vertebroplasties, mostly in the private sector. But when the same patient presents with this kind of fracture, then immediately, they're like, oh, it's a pelvic fracture, let's leave it alone and send Granny home. And that's what I'm trying to undo with this tonight. So you need to be as aggressive and as vigilant with treatment of these patients. So you must act with the same aggression and vigilance. And if you don't operate on them, we know that hospital stay is anything from 9 to about 45 days. Now, interestingly, 1 year mortality in patients with FFPs is 27%, and the 5 year mortality is 54%. And those are the stats that you get for hip fractures, and that's why you get told to intervene, have your multidisciplinary teams, have your operations ready, and just treat them aggressively because you fear those mortality rates. But you know what? FFPs have exactly the same mortality rate. So I'm going to keep emphasizing the point that we need to be as aggressive with them as we are with neck of femur fractures because it's a very similar injury. And when they do present with a non-union, so they present with something like this, which again, you will not often see in young patients. I mean, the only pelvis non-union you're ever going to see is a transverse acetabulum fracture in young patients that was not treated surgically. Every other pelvis fracture tends to unite, unless there's loss of bone in the inferior ramus, but all of them will unite. So it is very unusual to see a non-union in the anterior part of the ring. And when you do, especially in the elderly, you must actively exclude a posterior lesion in the ring. And we do that by doing a CT scan. So here's a CT scan that confirms the non-union in front, but look at the sacrum posteriorly. You can appreciate there is also involvement of the posterior bit of the sacrum. So now immediately, this is no longer just an anterior part of the ring, but also because of the osteoporosis, it's very difficult to appreciate the posterior lesion unless you go and look for it specifically. And sometimes if they present before the sacral fracture is visible on X-ray or CT scan, if you do an MRI, you'll pick it up on MRI as bone edema, and that's what this patient has. So it's a presence of a sacral fracture, but it's just not visible on CT scan just yet because it hasn't displaced to. So here's the first example. A 78-year-old female comes in. This is on the case you've just seen. And of course, she was treated the same way that we treat them all, sent home and never given a date. And by 3 months, she's like, you know what, I'm not coping. Comes back to hospital, and that's what she looks like. So it hasn't united, but not only has it not united, it's getting worse. And so again, gets sent home, comes back at 6 months. And that's what her X-ray at 6 months looks like. So now she has an established non-union. And if you look at the CT scan, you can appreciate now involvement of the posterior part of the sacrum. Again, nothing was done for her, told to go home and goes home. And, it's a pelvis fracture, Granny, just wait, give it time, it's going to heal. And that's her at 18 months. So what's happened now? She's frail, she's lost her muscle mass, she's got sarcopenia, and she keeps falling. So she's fractured now the other side as well. You can appreciate the posterior lesion, but importantly, also has a neck of femur fracture from the fall. So this is something that is potentially preventable if we are aggressive in their treatment. And many of them will present actually initially with what you call a warning fracture or a cry for help. And I mean, I'm not going to ask you to put your videos on or vote, but I know that many of you have treated an elderly patient with a distal radius fracture in the last 3 months. And I'm willing to bet that more than half of you did not investigate that patient for osteoporosis. You just put a plate on, put a pop on, and sent them home and didn't worry about the underlying problem. And I can assure you, you are not alone. In many places around the world, even first world countries, less than half, in fact, at some point it was sitting at 60% of patients that present with an obvious osteoporosis fracture do not even have the word osteoporosis mentioned to them. And then another 15% will have the discussion, but it doesn't go beyond that. So it'll just be this discussion only, but no referral for treatment, and certainly no MDT approach for their treatment. So what are the challenges facing us with these patients? So they present, of course, with abnormal bone because it's soft pelvis bone. There's very few channels for screw placement if you have to fix them. Many will have medical problems, and importantly, many will possibly be on blood thinners as well. Some have had cardiac stents, so they are on anticoagulation therapy. And the days of Granny just, having low expectations in terms of their physical function are over. Everyone wants to be active until, or at least for as long as possible. And also, dare I say, there's insufficient knowledge about osteoporosis by orthopedic surgeons. And even those that do know about osteoporosis don't often appreciate the importance of secondary prevention. So it is important to have a multidisciplinary team, consisting of surgeons, consisting of either a geriatrician, or you can have a physician or endocrinologist, but there needs to be someone with an interest in osteoporosis treatment and prevention of further fractures. We have a unit at Holeski. This is like the first in the country for both the public and the private sector to have this dedicated orthopedic and geriatric service for osteoporosis. And so any MDT has been shown to shorten hospital stay. It's been shown to reduce incidence of sarcopenia and muscle wasting. It's been shown to reduce complications like DVTs and pneumonia. And importantly, mortality is much more improved with this kind of service. And further fractures are also prevented because everybody gets medication and they get proper follow-up for their fractures. So why are we important in this chain? Because often when a patient comes with a fracture, the orthopedic surgeon is going to be the first patient that gets called. So it is then up to you to initiate the team approach. And importantly, if you don't do it, nobody else will do it. Like I said, because the patients come to you. Unless there's a specific person that's dedicated to provide to doing this, like just to being the liaison for everyone. So if you're that person, then that person does it. But if not, you as a surgeon must initiate that. I'm not saying you must do all the osteoporosis work, but you must inform the team and put the team together. And it's great to have protocols in place so that even if you're not around, the protocols get adhered to. So we've just updated our protocol at Holiskia, and it is actually sent out today to registrars and interns. So the whole approach, at some point there was a hashtag for it, and it was called Capture the Fracture. It just means that when the patient comes with a fracture, that is an opportunity to capture them and treat everything else about osteoporosis. Because remember, if it wasn't for the fracture, they would never have come to hospital. So hence the expression capture the fracture. So what do we do with them once they have an established non-union? The only way out in those ones, unfortunately, is surgical fixation. And it's the same principles that you need biology, you need stability, and the way you provide biology is by cleaning out the non-union scar and bone grafting. And often we take the bone graft from the iliac crest. And then if you don't do it properly, you leave some change behind. So you see, we did a bone graft from her, but there was some bits that fell off afterwards. But anyway, on the right of your screen, that's now her, and that's united. So if you treat them early, they do unite. And this is a 56-year-old that fell off a stationary bike at home. So comes in with this X-ray on the left, and is there something there? Yes, no, difficult to say. And gets sent home, rightly so, because there's no obvious fracture, and then comes back just a week later saying, "Now listen, I'm not coping." And the repeat X-ray, luckily maybe from a slightly different angle, shows that she's got a superior ramus fracture on the right. Again, nothing to be concerned about. But now she comes back at 6 weeks, and this is when most people don't believe me here. So I'm going to show you the first X-ray and show you that she had spine fusion at some point, and she had bone graft taken from the right iliac wing, and hence that defect that you see there. So this was her on admission, and this is the same patient, same bone graft harvesting site at 6 weeks, and see what she looks like now. Old fracture is still there, but now you can see that she's starting to develop fractures on the other side as well. And, comes back 3 weeks later, same patient, and now you see she's got established fractures on both sides, superior and inferior pubic ramus. And then 12 weeks, same patient, looks like that. And I just put the first X-ray back so you can see what she looked like when she came in. So this is her 12 weeks. This is now, and this is where again sometimes definitions fail us, because you can't call something like a non-union until a certain number of weeks have passed. But at 12 weeks, it's not incorrect to call this, if not a non-union, then it's an inevitable non-union or impending non-union. So we did a bone density scan for her, and where's the result? But anyway, you can see she's got minus 3.4, her T-scores in the lumbar spine, minus 3.2. So that is deep into osteoporosis territory. And you don't expect it in a 56-year-old, but also look at her vitamin D levels. Sorry. So vitamin D was also low, as you expect it to be higher than 30. So surgery for her, same principle. We took more bone from her previous bone graft and grafted the anterior ring, and then put sacroiliac screws on coming from the left. And those are post-op images, and that is her, and she went on to unite. So again, same principles, bone grafting, biology, stabilization, but importantly also treat the osteoporosis, and they will unite. So the issues here are, of course, now where do you put your screws? And if you do a 3D recon CT, you see even some of them even have holes in the thin part of the iliac wing and the bait there. So there's very limited areas, or at least limited areas with good bony purchase. So you need to know where those areas are. And for many of them, it's the lateral part of the sacrum, and then nothing in the middle. Nothing medial to that, and then the middle part of the sacrum, and then the other side of the joint. So I'm going to show you now that we now do transiliac screws for that reason. There's always good bone into the posterior column of the pelvis, so we have to utilize that corridor. And then in the supraacetabular area, there's always good bone there. So that's where you aim for your screws to go. Everywhere else is just poor quality bone. Next to the symphysis is also a little bit good, but not as great. So these are just the intra-op images of, with a little bit going in. This is a patient with bilateral, injuries. And if you do the anterior intrapelvic osteopar approach, you're able to put plates on both sides. But again, like I said, importantly, you need to utilize, it's called the fossa screw that starts in the superior ramus all the way into ischial tuberosity. Okay, so why do we use transsacral, transiliac screws? And like I said, it's just the cortices that you get. So you'll get one cortex on the outer ilium, one on the inner ilium, and then you've got the lateral part of the sacrum. Nothing in the ala here, but in the promontory, there's good bone. And then you cross to the other side. And the question is, why are you crossing both sacrum, sacroiliac joints? And there's very little movement. Maximum is 7 degrees of movement in your sacroiliac joint. It's a very stiff joint, and patients actually do not feel the difference. Both young and elderly, if we cross the joint and ask them like, how's the other side feeling, they've got no clue that anything happened on that side. But the amount of extra purchase you get is that much more. That this is an important corridor to use and an important skill to have. And that's what the screws look like. So you've got one in the S1 segment, and then if you can, imagine all patients, you will have an opportunity to put a screw between S1 and S2 as well. So S1 screws segment and S2 segment screws, and that gives you nice, good stability. And intra-op, this is now when you cross onto the other side. This is the outer part of iliac wing, and you've got your two screws going. That is a very stable fixation. And then what you see here is the so-called, it was called LC2 screw or lateral compression 2. It's the same trajectory that you use if you're using a supraacetabular X-fix. And we basically use it in patients now who have extra iliac wing involvement with these FFPs, and this is just also for added reinforcement. It's not always, so this is another example. So patient had known with a severe osteoporosis and now complained of ongoing lower back pain. Eventually, they MRI'd her, and she's got bilateral involvement of the sacrum. And for her, luckily, there was nothing anteriorly. You can see she had a hip replacement on the left side. But here you're able to do, two transsacral screws. Even if there is instrumentation in S1, there's often, enough space to get the screws across. And just that extra stability that she got from the screws, that then takes care of her pain, and she was much more comfortable afterwards. Okay, so this is an example of a type 4 FFP. So, presents with this kind of case, and you can see that she's got, trying to get rid of something on my screen. Okay, so she's got involvement on the iliac wing, look at that, and she's got right superior ramus involvement. And like I said, you don't see much on the X-ray in terms of posterior lesions, but you can see there's something going on in the sacrum. And this is a different view, again confirming the involvement of the right iliac wing. That's the inlet view. So here, as you can see, what's happened is that the whole spine sacrum has sort of invaginated into the pelvis because of her body weight, and she's so osteoporotic. When she stands, her pelvis cannot sustain her body weight, and the whole thing is beginning to collapse into the pelvis. So you don't want to get to this stage, and you hopefully are going to intervene before this. That's a CT scan, confirming involvement posteriorly, just different slices, again confirming bilateral sacral involvement. Now, the difficulty is that this is what you see intra-op, and when we do the screws, we do them, with obviously certain anatomic landmarks in mind, but the minute you've got all these narrow channels overlapping, it becomes very difficult to see intra-op, and then it becomes unsafe to, to put the screws. But, for her to be comfortable and to prevent her spine collapsing into the pelvis, the only way is to intervene, because even when she's sitting in a wheelchair, her spine is still pushing down. And that's the ended view, again, appreciating the displacement. So the whole idea here is, with this, you're not trying to get anatomic reduction. That's going to be very difficult because this is like a long-standing non-union with lots of fibrous tissue, but you want to stabilize it in situ. Outlet view, here, this is where you work with an eye of faith, that if you can see the top of sacrum and you aim your screw just above that, you should miss the S1 foramina, but that did look like the S1 foramina intra-op. So that's, so intra-op images, plating the iliac wing, starting on the right, and then preparing to put a sacroiliac screw from the right. And now other side also plated, guide wires left in place for eventual screw placement. And now bilateral ilium fractures fixed and the two sacroiliac screws going in. And also now the LC2 screw, which just reinforces your fixation of the iliac wing because of the initial displacement that you saw. So now we've got two plates, we've got two trans-iliac screws, and we've got two LC2 screws. Different view of the same, just showing you the hardware placement. Now, what we wanted to do for her, because remember she's got involvement anteriorly as well, but she was just too frail, too unwell intra-op. I mean, this is a major outing. So eventually we actually just had to abandon the front part, also accepting that the front part isn't as important as the posterior part. but this is what she would have looked like ultimately with the front plate as well. But like I said, we just dropped that part um, and prioritized posterior fixation. And because you couldn't see our landmarks intra-op, then you're bound to do, well, it's safer to do a CT scan afterwards just to confirm your placement, and the screws are nicely in place. So to summarize, so we're seeing, more and more of these FFPs. So whenever you're faced with a patient or elderly patient with a pelvis fracture, you need to have, a much lower threshold for review. Don't discharge them on day 4. Call them back at 6 weeks and see what's going on. And, once the fragility fracture is established and they present with an established non-union, then for those ones, outcomes with conservative treatment is very poor. So you need to, to fix them, and you need to act early. And, like I said, you have to restore biology and offer stability, and also, treat the underlying problem, which is the osteoporosis. And that's where the multidisciplinary teams come in. So I'm going to end it there and stop sharing my screen. And also, so just to say that, I deliberately just wanted to show you something different, because I know that you see mostly elderly patients during the MO rotation, but at least, just be on the lookout for, sorry, you see mostly young patients, not elderly, and the elderly that you see are often, the LC1 type fracture, maximum LC2. But once the problems set in and they don't unite, you don't often see them at your hospitals because they come to us. But what I've just presented now is what we then have to deal with once they have not united. Okay, so I'm going to end it there. Thank you for your attention. And yeah, I'll take questions and comments.